So what I'm going to talk about today over lunch is ethical issues that often arise in clinical research and in the context of clinical research, and specifically the IRB, the Institutional Review Board's role in maximizing what I'll refer to as the three cardinal ethical principles that underlie all research with human subjects. Obviously, this can be a somewhat dry topic, although important, so I'm going to do my best to bring as much energy as I can during the lunch hour. So what I'm going to spend a very brief amount of time on is just discussing how we got IRBs, because that's important to understanding the underlying ethical principles and the framework that the IRB brings to the discussion. But as Dr. Munir alluded to, the purpose of these research boot camps is truly to facilitate the research process. And with that aim in mind, what I'm going to spend most of my time discussing are specifics. Specifics related to the IRB. What does the IRB look like? What happens during the review? What are the levels of review when you go to submit a protocol, in many, many specifics? Obviously, we need to spend some time on the informed consent process, because it's very important not only to all clinical research, but especially clinical research in a healthcare setting. And no discussion of clinical research in a healthcare setting would be complete unless we also discussed the implications of HIPAA legislation in the context of research. As time permits, I'm going to end looking at two very recent studies from the perspective of what would you do if you were on the IRB. Because as Dr. Munir alluded to, our goal is over these next 3 sessions to really discuss the IRB process in more detail. And the take-home message should be that whether we're talking about the KC system and the particular questions that might be asked of the KC system or your protocol, or whether we're actually observing a mock IRB in process, everything is driven by the ethical foundation and framework that we're going to discuss today. Okay. All right, so in one slide, here's how we got IRBs. Okay. The history of IRBs actually started with the atrocious experiments conducted by the Nazis during World War II. Okay. Horrific does not even begin to describe what was done. 2 brief examples are, in one case, there were captured Russian soldiers, and the Nazis were looking at ways to prevent hypothermia, and so they dunked these soldiers in a tank of ice water for up to 5 hours. In almost all cases, they waited until they died and recorded it as data. Okay. In another case, they were looking at high-altitude experiments to see how high their pilots could safely eject if they were shot down. They took prisoners in their camps and put them in low-compression chambers, low-pressure chambers, and basically just kept decreasing the pressure until they died, invariably. One of the take-home messages is that in all cases, none of these individuals ever had a say in whether or not they even wanted to be a part of that research. Okay? And obviously in all cases they had no idea what the risks or the benefits were, and in most cases the plan was to just go ahead and keep going until the person died. Okay. Out of the World War II, we had the Nuremberg trials, and we had the doctors' trial, which put 23 Nazi doctors on trial. 7 of them were sentenced to death, 7 of them were acquitted, and the rest of them were given up to and including life sentences. What's most important for us in the history of IRBs is that out of the Nuremberg trials, we got the Nuremberg Code. And this was the first time where an attempt was made to get on paper what should be the ethical principles guiding research. And so this is specifically research with human subjects. And this was the first time you really started to have discussions about things that people ought to have the right to decide whether or not they want to be in a research study. People ought to know what's going to happen to them. People ought to know what the risks and benefits are. Okay? Unfortunately, unethical research practices were not limited to Europe. Okay? Around the same time, there were several very unethical research studies that were going on actually in the United States. And I will only mention 2 here because, again, I said I'd make this brief. This could actually be its own boot camp, its own lecture series, talking about the history of IRBs. How many of you have heard of the Tuskegee syphilis experiment? What happened in Tuskegee? You got it. It was the Public Health Service. It was conducted from 1932 to 1972. They enrolled poor African-American sharecroppers, okay, in the study. many of whom had syphilis, and the goal was to take a look at what is the natural progression of untreated syphilis. Okay, the problem being in 1947, penicillin came about as a cure. Those individuals that were in the study, they did not know what the study was. That's another ethical problem. Okay, they were only told that they were getting free medical care for bad blood. Okay, and they were not offered that treatment when it became available, which is ethically horrendously problematic because we all know what can be the natural progression of untreated syphilis. So that was the Tuskegee study that was going on in the United States. How many of you have heard of Henrietta Lacks? It's okay if you don't remember. So Henrietta Lacks was a poor African-American woman that presented to Johns Hopkins University in 1951 for treatment of her cervical cancer. Okay. During that treatment, Dr. Gay biopsied her cervical, some cells from her cervical mass, and that actually ended up creating what's been referred to as an immortal line that has been used in cell research up to and including this day. Okay, it's called the HeLa line. It was actually used by Jonas Salk when he was, developing the polio vaccine, and at last count there was tens of thousands of patents based on research using the HeLa line, which just kept multiplying and multiplying and multiplying. She had a very aggressive cancer. From an ethical perspective, again, the bottom line was she had no idea what was happening. Okay, she was not told what was going to happen. There were researchers that showed up in the 1970s in her community trying to find family members because they wanted to do DNA testing, and they had no idea what was going on and that this line even existed. And also problematic, as was seen in Tuskegee, we start to get into this concept of justice, which we're going to talk about, where you're picking people that might be vulnerable. A particular class of society, in this case, low socioeconomic status African Americans. So it was happening here. And because of that, in 1974, the National Research Act was passed, which formally created IRBs. This Research Act also created what was called the National Commission, which was tasked for putting down on paper, for our purposes, what should be the guiding ethical principles when we talk about doing research with human subjects in the United States. Okay. In 1978, they put down these principles, which we're going to talk about in the Belmont Report. You get extra credit if you know why this is the Belmont Report. Anyone who hasn't seen the talk before? It was called the Belmont Report because they met at the Belmont Conference Center in the Smithsonian in Washington, D.C. So when the final Jeopardy question comes up and you win and Alex Trebek asked you where you heard it, you can say you heard it here. But that was why it was called the Belmont Report. Finally, in 1981, 45 Code of Federal Regulations 46, in a very omnibus way, came up with the entire blueprint that IRBs use when we are reviewing research. So throughout the rest of this presentation, you will see where I will put up various elements of 45 CFR 46. If you have any difficulty sleeping, and it's 2 in the morning, this is a good one to try if Ambien's not working for you. Okay, but 45 CFR 46, again, is the blueprint that we use, okay, as IRBs, when we are looking at reviewing research. And if you're ever wondering and having questions, you yourself can go there and see what the IRBs are looking at when we're reviewing your research protocol. All right, believe it or not, that was a brief history. So let's get down to why we're really here. The overall ethical framework for everything the IRB does, okay, whether in this is the underpinnings. Everything we do. There's 3 basic principles. The first is autonomy, or respect for persons. And this is essentially the belief that human beings ought to have the right to determine their own destiny. Okay? They ought to have the right to say, yes, I want to do this study, or no, I don't want to be in this study. Okay? And also, most importantly, if they do not have the capacity to do so, if they have diminished cognitive impairment, that those individuals ought to be protected. And in this case, we can use legally authorized representatives and proxy consent and things of that nature. What's the number one way in clinical research you think that this is manifested? What do we usually do, study procedure-wise, to maximize respect for persons? Informed consent, and that's why we are going to spend a lot of time on the informed consent process, because it is so important. And obviously, the cases I highlighted talk about what happens when you don't respect people, and they have no right to choose whether or not they want to be in research. The second one is beneficence, which it took me a while to pronounce correctly, but I think I'm finally there. And this is just the principle, again, that we ought, to the extent possible, maximize benefits and minimize risks in any research study that we do. And when an IRB is looking at a protocol, one of the things we critically look at is the ratio favorable? You know, are the benefits greater than the risks? I mean, worst case scenario, equal, but we would always like to see benefits outweighing risks to the extent possible. And the third is the justice consideration. And this talks and speaks to the point that no one segment in society should unfairly or unduly shoulder the burden of research or the risks of research. But also, in what is often lost in this discussion, is that no one segment or group in society should be excluded from the potential benefits of research. Okay, so we can all see when we talk about Tuskegee, okay, or we talk about Henrietta Lacks, what can happen when you ask one group to unfairly shoulder the risks. But what about the benefits? What's one group you think that is consistently excluded from the potential benefits of research? This is not discussed as much. It's actually children, because research with children is problematic because of parental consent issues. Oftentimes drug companies don't want to take the risks involved if something goes wrong with kids. And so because of that, many drugs we have come to market, we absolutely have no data on how they do in a pediatric population. And so it's both sides of the coin. These then are the three main cardinal ethical principles that underlie all research with human subjects. And not surprisingly, IRBs, we are responsible for approving research based on these three ethical principles. It is our job to ensure that these principles are maximized to the extent possible in every protocol that we review. And 45 CFR 46, again, that's just where it's showing that the IRB also is the entity that has the authority to review and approve and require modifications or disapprove all research being conducted. So let's get into the specifics. What does an IRB look like? Okay, because sometimes I think in the past there's been this iron curtain between IRBs and researchers that ought not exist, because we all should be, in the same, existing for the same purpose, that we're here to do good research and we're here to protect human subjects while doing that good research. Well, you have to have at least 5 members. You can have more. Okay, at WVU we've probably got 30 members between the two boards that we have, but you have to have at least 5. Okay, the most important thing is they must be from a diverse background. This makes sense. We want to make sure that we have individuals on the IRB that as much as possible reflect the surrounding community and reflect the different viewpoints that exist within humanity. One of them, however, must be a scientist. So although you can't have all physicians or all scientists on a board, one of them should be a scientist, and this person is usually instrumental in helping us when we talk about trying to determine beneficence considerations and weighing the risks and benefits of protocols, especially medical protocols. One must be a non-scientist. Okay. Scientist is usually defined as somebody with a terminal degree, an MD or PhD. Non-scientist is more open to interpretation. Most importantly, one must be non-affiliated with the institution, must have a community member. Can you imagine if an IRB had existed and a community member from the Tuskegee community had been on the board reviewing the Tuskegee protocol? Do you think that that protocol would have been approved? Not a chance. Okay, and so this is kind of where it all started and where it comes from. Very importantly, you have to achieve quorum. We will see what can happen if you don't achieve quorum later on. In my 8 years on the board, I've only seen this happen twice where we lost quorum. Either it was inclement weather and we had members that couldn't make it in, or members got paged away. And if you lose quorum, the meeting stops. It has to stop, which is really bad, because if you're on the meeting agenda and you're waiting for your protocol to be reviewed, it may not be reviewed. So we do everything possible to ensure that we never lose quorum, but it has to stop. And if it doesn't stop, there can be very negative ramifications. Okay, so that's what an IRB composition looks like at each meeting. And at each meeting we document who's the scientist, who's the non-scientist, who's the community member. Okay, now we get into the specifics. If you're putting together a protocol and you're going to be like, what level of review is it? Okay, what's the pathway for review? There are 3 primary levels of review: exempt, expedited, and quorum, or convened board. Exempt research, by definition, is minimal research that has to fit into 6 very specific categories that you can find in 45 CFR 46. Common examples are anonymous surveys. Although if your survey is not anonymous but is non-sensitive in its questions, it could potentially be exempt. But definitely anonymous surveys are usually exempt even if they have sensitive questions. Retrospective studies of existing review. Here's your chart reviews. Okay. There's a technicality that if you ever have questions, because we only have an hour here and it's a lot of technical detail, hopefully my information will be shared. You can always call or email me and I'd be happy to guide you through the process. But if you're doing a chart review at WVU and you're not retaining identifiers of any type, then you can qualify for an exempt category 4. If you're doing a chart review and you want to retain identifiers, like you want to keep the MRN or you want to keep a code linking your data collection sheet to the MRN, then it has to be expedited category 5. Again, that's a technical detail that we can talk about later, but if you're not keeping identifiers and you're doing a chart review, that will qualify for an exemption. And of course, some educational research on existing curricular methods might also fit into this category. Here's the most important take-home point for today. Okay. If you go to 45 CFR 46 and you read the regulations related to exemption, it says that if you fall into one of these 6 categories, then the rest of this document doesn't apply to you. Have a nice life. Okay. Institutional policy invariably, and WVU is no exception, says you still have to check with the institution. Okay, so you still have to submit an exempt application to the Office of Research Integrity and Compliance. One person looks at it. It's usually a matter of days, hopefully no more than a week, and and either they agree with it or they don't. Okay, the biggest mistake we've seen is investigators unknowingly saying, I thought it was exempt and I interpreted that to mean that I didn't have to check or do anything further. You still have to check, but this is just the exemption route. If it doesn't fit into one of the 6 categories, it can't be exempt. Okay, you can always call the research office and ask. If it's not exempt, then you're left with expedited or quorum review. The line of demarcation here is the level of risk inherent in the study. Okay, according to 45 CFR 46, the level of risk is defined as, minimal risk is defined as the procedures that are described in the protocol tend to indicate that the risks involved would not be more than that which is encountered in daily life or during the course of routine medical procedures or psychological testing. Is that subjective? Yeah. But so is life, and so it is a judgment call. The investigator is the first person to make this determination. When you're filling out your application, and Lilo will go over the specifics of KC, you will fill out whether you think this is exempt, expedited, or quorum. Okay? If you think it's expedited, then it gets sent out to one reviewer. We usually like to turn those around within 10 days, if we can. If it is more than minimal risk, then it goes to full board. Okay, at WVU, we have 2 boards. We have the gold board and the blue board. Wonder why they came up with that. Okay, the gold board meets on the 2nd Wednesday of every month. The blue board meets on the 4th Wednesday of every month. Your deadlines, if you have to submit a protocol to either board, are 1 week prior to the meeting, which is very judicious. So the 1st and 3rd Wednesday would be your deadline for submitting a protocol to be placed on the agenda at the full board meeting. Okay, the expedited categories, there's 9 of them. 7 of which we use. And again, our policies are all on the website. You can see if you fit into one of these categories. When you get into the KC system, they'll be on there where you can select, I think it's one of these. I mean, you don't have to memorize them. Okay, they're on there. If you have a study that's minimal risk, but it doesn't fit into one of the expedited categories, then it has to go full board. That's a rare occurrence. The take-home message here is that this is driven by level of risk. Okay, and if it goes full board, then the board will meet and we can now talk about some of the decisions that a board can make or a reviewer can make. 3 primary recommendations. You can approve a protocol. Okay, it happens. It usually doesn't happen right away. Usually there are some minor things, but ultimately this is the goal of all research and all protocols. You can disapprove. We can disapprove a protocol. I will tell you this is quite rare. Okay, in my 8 years on the board and probably 1,000+ protocols that I've seen, I've only seen 4 or 5 outright disapprovals. Okay, the only time I have ever really seen this happen is because the ethical principle of beneficence cannot be satisfied. This is the only time I've seen this happen, where the board, after trying to work with an investigator, cannot be ensured that the benefits outweigh the risks. that the risks are just too great in relation to the benefits. And it has happened, but it is quite rare. A very important point, of course, you can defer it as well. And this would happen if you're an expedited reviewer and you don't believe that you agree that this is no more than minimal risk. You can defer it to the full board. A full board can look at a protocol and say, I don't think we have enough information to review this, and defer it back to the investigators. A very important point, technically, is that an expedited reviewer cannot disapprove a protocol. Okay, and that's in the regulations. Only a full board, only a convened board, can disapprove a protocol. Okay, once a protocol is disapproved, which fortunately is a rare occurrence, no institutional official can overturn that ruling. And again, that makes sense because first and foremost, the board comes together for the protection of human subjects and has to be independent of the institution. Okay, let's say you get your protocol approved. That's obviously the goal. Okay, you've gone through the submission process. It's been either reviewed. You know, exempt protocols are a little different. They have a 3-year expiration date. Let's say you have an expedited or a full quorum protocol that's approved. By law, the WVU IRB and all IRBs have to review it at least annually to make sure there were no problems, to make sure there were no additional risks or anything that's happened that could change whether or not we feel that this can continue to go forward. We're looking, is the risk-benefit ratio changed, the beneficence criterion? Okay. It can be less than a year. If we have studies that we're concerned about the risk, then we will say, oh, we'd like to see it quarterly. Some cases we'd like to say, check back with us after you enroll your first 2 patients so we can just see that there were no problems that were unexpected. A nice segue into our next section, though, as you can see also in this area of code, that we have the authority to observe the consent process because the consent process is so key. So now what I want to do is I want to switch gears into the consent process, which is what we talked about being the manifestation of the ethical principle of autonomy or respect for persons. True or false? This is my favorite. I teach a course called Clinical Research Methods and Practice at the university. And those of you that know me know I'm very big on this. Informed consent is only valid if a signed consent form is obtained. True or false? You got a 50-50 chance. False. I mean, I'd jump up and down if I wouldn't lose this. It is false. Because if you remember nothing else today, please remember, informed consent is more than a document. It's a process. Okay, I'm not saying the document's not important. Okay, we live in a legal world, but it is not the document itself. It is the process, the interaction. So it is a process, not a document. Rather, it should be about the spirit of informed consent, and you can see what I bolded there. You know, is there sufficient opportunity to consider whether or not to participate? That can be very challenging. I do emergency medicine research. I do a lot of stroke research. That's very challenging in an environment where time is dependent and you have to get the therapy or the drug as quickly as possible to get consent. Does it minimize the possibility of coercion? This is a concern a lot of times when we see professors that want to enroll their own students into studies, because you just want to make sure that the students don't feel coerced to participate because they're afraid they might get a bad grade, if they don't participate. Is it in a language that's understandable to the subject or the representative? This means no higher than the 8th grade reading level. Okay, and we look at that, and oftentimes we will ask that particular technical words be translated into lay language. And a very important one, cannot include any exculpatory language. Does anybody know what exculpatory language is? Exculpatory language is any language where you appear to or actually give up your rights. Okay, and back in the day, you had some drug companies that would try to put language in a consent form that would say, basically, thank you for participating, but if something bad happens to you, we're not paying for it. Okay, and the law specifically says you can't do that. You cannot waive or give up any of your rights as a subject if you're going to participate in a study, and that's something when we review protocols that we look at, all the time. It's a very important point. So, it's not just a document. Unless you are doing a study that's subject to FDA regulation, which a lot of drug studies are, okay, you can actually waive the requirement to get a signature. Okay, and there are 2 main reasons for doing that, as you can see. One reason would be if you're concerned, one reason would be if you are concerned that you have a sensitive study and the only record that's linking the subject to the study is the consent document. And if that's the case, the board can say, yeah, we agree with that. You can go ahead and give them a consent form, but you don't need to keep a signed copy on file. Okay. The other would be if you're just doing a study in which no consent document would be required if you were a non-researcher doing the study. And we see this a lot with survey monkey studies, non-sensitive surveys. You can waive that requirement. It does not mean that informed consent goes away, which is why I always say it's a process, not a document. You're still having the discussion with the subject about what's going to happen, about the benefits and the risks. It doesn't go away. It just means that the emphasis is not on the document alone. This is just another example of how it can be modified. You don't have to memorize the requirements if you ever use it. The policies are on our website. This is just an example that you can actually use a short form of the consent document. Unfortunately, most consent forms, especially in clinical trials, industry-sponsored trials, can push upwards of 20 pages. Which really gets into sufficient time to consider and really get through the actual consent process. You can actually fully waive consent. This is rare though. This is very rare because usually there's some type of consent going on, even if it's just like a cover letter, with the information given to subjects for like an exempt type survey. If you waive consent though, we have to look, are all four of these criteria present? And all four, those are ands, it's not or. All four have to be present, have to be minimal risk, okay? Waiver or alteration will not adversely affect the subject's rights. What that means is that if I'm in the study, would I be upset to find out I was enrolled in the study, if I came to? Because this is usually like traumatic situations. The research cannot practically be carried out, and whenever appropriate, you would give more information to subjects if they were willing to receive it. I've only ever seen about one or two of these. It was in the context of trauma research where something very minimally invasive was being done that the board thought had benefit on trauma patients that came in that were unconscious, and there was just no way you could get consent. The FDA, if we have time here at the end, does have an exception from informed consent for emergency research, but otherwise the FDA, it's very hard to waive consent up to and including a signature with FDA-regulated research. Let's talk about HIPAA, because HIPAA affects the consent process. We all know that HIPAA came about in part to protect our health information. Okay, I want to talk about what we mean by health information. Okay, because this is very important to the point I'm going to make, which is a specific piece of information that all researchers should know. So health information is any information about an individual's past, present, or future physical or mental health or condition, provision of healthcare services, and billing data. Okay, what is most important when we talk about HIPAA from a research perspective is that this information only becomes protected, PHI, and thus subject to HIPAA considerations, if you pair it with one of the 18 identifiers. Okay, you don't have to memorize the 18 identifiers. You can Google them and find them. Okay, obviously name, date of birth, date of service are some of the more common ones. But the point is that in research, HIPAA doesn't apply if you only collect health information and you're not pairing it with an identifier, or if you're only collecting identifiers but you don't have any health information. Okay, that's an important point. Okay. All right, there's the other identifiers which you don't need to memorize. So if you have de-identified data, that's not subject to HIPAA. If you're not a covered entity, HIPAA doesn't apply. Now, from a WVU perspective, most of WVU is a covered entity. I mean, the traditional definitions, healthcare provider, health plan, healthcare clearinghouse, that's true. But if you're doing research at WVU, most of WVU is a covered entity. So what's more important to remember is what I talked about, that you have to have both situations present, health information and paired with an identifier. If that situation is present, then you have to get either a waiver of authorization from the IRB or written authorization with a signature. Okay. Currently at WVU, all prospective research that involves PHI requires a signed HIPAA authorization. We do entertain and often grant HIPAA waivers of authorization for studies, retrospective studies involving existing data. So if you put in an exemption application because you're doing a chart review, you have to put in a HIPAA waiver of authorization. Okay, so that is another reason why you can't just say, I thought it was an exempt and I didn't need to check. okay, with the university. The problem is that unlike informed consent in 45 CFR 46, there's currently no provision for waiving the signature. And this can create a lot of problems, especially with some of our social behavioral studies, whereby individuals will want to, BMI, that is a really popular data point, but height and weight are considered health information. And so a lot of times if you're collecting height and weight or you want to get a BMI and you're parent with an identifier, then you're getting into needing a HIPAA authorization. The authorization can be embedded into the written consent form, but that's just something to keep in mind in terms of HIPAA. Okay, so I'm doing good on time actually. Are there any questions so far? I know this is a lot to digest. Again, my contact information will be made available and you can email me, call me anytime. I want to end talking about two cases, recent cases, actual cases, to start getting you thinking about, preview of coming attractions when we have kind of this mock panel or this mock board. What would it be like to actually be on an IRB, okay, and be actually reviewing protocols or being an expedited reviewer, okay? And so these are actual cases. All right, two UC Davis neurosurgeons were injecting the open head wounds of 3 terminally ill glioblastoma patients that they had with gut bacteria, so-called good bacteria, under the hypothesis that the infection that would cause would stimulate the immune system to fight the cancer and thus increase the survival time of what is obviously a very devastating disease. Okay. First question is IRB review required? Why or why not? What do you think? Yes, and why? So there's two things. It may seem self-evident, but it's not always. One, we're dealing with human beings, okay? And two, because they're doing 3 patients, that would suggest that they're attempting to create generalizable knowledge. So those are the 2 primary things. Your research on human subjects, and you're attempting to create generalizable knowledge. If any of you are doing research like on HCUP data or de-identified data sets, that is not considered human subjects research. That's another important point to make. You can check with the Research Compliance Office and you can actually receive a not human subjects research designation, but it's not considered human subjects research because if it's truly de-identified, it can't be tied back to a living individual, even if that individual is still living. So that's another point to make. So yes, research on human subjects, and it looks like they're trying to create generalizable knowledge. What level of review then would this be if you were putting together your protocol? Remember, there's 3 levels of review. Full board. Why full board? Right. 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 So and especially the last point you made is this is clearly more than minimal risk. Okay, so remember that was the line of demarcation. This is clearly not something that you're going to encounter in everyday life. If you do, that's a pretty interesting life, but we would say that you're not encountering this in everyday life. This is clearly more than minimal risk. So, what are the relevant ethical questions that the IRB should address? Because again, the take-home here is this is our ethical framework in the review process. Autonomy, what do you think? This is a little bit different one, which is why I included this case, because in most cases, these individuals, although they are glioblastoma patients, may have the capacity to consent. Okay, their disease may not have affected their capacity to consent. Okay, but what you have to consider is terminally ill patients are desperate. Okay, and so you want to make sure that their desperation doesn't preclude them from having sufficient time to weigh all the benefits and the risks of the study. And there's things we can do to make sure, or to maximize that would be the case. And I would submit one of the things a board would look for would be, does the patient have a chance to take the consent form home and discuss it with their family member and digest it. And that would help maximize, that they really have time to say, yeah, I want to do this. I want to be a part of this. Even though I'm desperate, I understand, and I still want to be a part of this. What about beneficence? So what do we do in a case like this when we see kind of a new therapy, or a new, drug? What does the IRB look for when we're trying a protocol? Well, we start asking questions about what is there any preclinical data, or is there any preliminary clinical studies? Okay, this is where the science member on the board will be very helpful. Okay, and we ask that, were there other animal and clinical studies? In this case, because it's a real case, there were only clinical anecdotes, and in fact, the FDA had requested more animal studies. Okay, so that's something we would try to consider if we were going to approve this or not. What about justice? In this case, it may not be much of a consideration, okay, but you should never forget that justice is the third ethical principle that we always have to consider. Is any one group being kind of asked to unfairly shoulder the burden of this research? I don't think that's in question in this case, given that it's driven by a particular disease, but you should always be mindful of that. So what did the UC Davis IRB decide in this case? I'm sorry? We have a vote for no. Anybody else? Anybody else want to vote yes? Oops. It was never submitted for full review. That's a bad day at the office, right there, okay? Instead, the PI sought what's called emergency use of a test article. So the federal regulations state that if you have a test article, and in this case it's a test article because the FDA also regulates biologics in addition to drugs. If you have a patient that's in a life-threatening situation and the physician feels that they would benefit from the test article, you can use it, and there's not time to get IRB approval. You can use it once, and then you have to report to the IRB within 5 days, you know, the actual encounter. And then the IRB will look at that and determine, was that a fair and true emergency use. Okay? The take-home message here is once and only once. If you then want to use it again, then you're getting into, now you're doing research, and you need to submit an application for review and approval. Okay? Unfortunately, they enrolled 3 before this was discovered. So the question becomes, what happened to the 3 patients? Well, sadly, 2 of them died, you know, pretty quickly after the surgery, secondary to sepsis. Okay. The third one ultimately had a wound infection, and they tried to treat it, but they later died as well. Okay. Yes.
In emergency situations, how fast can you get the board?
The question is, in emergency situations, how fast can you get the board to approve something? And the answer is no faster than the process we discussed, which is why you have this exception, where you can go ahead and use it once, and then if you think you're going to have to use it again, you know, put the protocol together and use it. And this is the only option available. So I think that's a very good question. Very good question. So hopefully you don't have more than one, you know, in a short period of time. There's nothing in the regulations to preclude a doctor from being a doctor. Let's say that, because that's the other side of that as well. If you have to do that because in your professional judgment, patients need it, then you do it. It's just no longer a research consideration and doesn't hit our board. But you know, typically that is the only mechanism they have available, once and only once. So that's a very good question. What happened to the investigators? They were excluded from doing research ever again. Although one of them I still believe is the chair of the Department of Neurosurgery. He's an endowed chair now, but he can't do research anymore, at least last I checked. The FDA, the university actually had to self-report, and again, that's a bad day at the office to the FDA about serious and continuing noncompliance. And last I knew, the FDA was deciding whether or not to do a for-cause audit, which can be a very, very unpleasant situation where they can come in and look not only at that protocol, okay, but at all protocols across the board. Could it get worse? Yes, it can. It's what we call the research death penalty, where the federal government can come in and suspend all federal funds at a university, all of them, for even one finding of ethical misconduct. Has it happened before? Yep, it happened to Duke. Okay, it happened back in 1999. And what I want to call your attention to is the reasons why it happened, because look at that. I keep hitting the wrong button there. IRB. Document a long list of failings, most of them related to the center's IRB. IRB was not keeping written documentation as required by law, as describing how it decided to allow various studies to go forward. So when we document our minutes at a meeting, we're documenting to the extent to which we felt that autonomy was satisfied, beneficence was satisfied, whether there were justice considerations, etc. Look at that. Discrepancy between number of members recorded as present in meetings votes and whether a quorum was present as required by law. The university was shut down for a period of time because of failings in the IRB. So one of the take-home points here is, first and foremost, the IRB does exist to protect human subjects, but it can also protect the institution, both the investigators and the institution. Conflict of interest is a huge issue, and in any IRB meeting, any member that has a conflict of interest with the protocol, perhaps they work with the PIs or the research team, anything that could be construed as a conflict of interest, they have to leave the room during the vote. And that is also kept meticulous track of because it's an emerging issue. Also happened at Johns Hopkins in 2001 because of a young healthy volunteer that died in an asthma study. And you can see again among the infractions, again, the IRB, convened meeting, failure to approve every study at a convened meeting of the Institutional Review Board, lack of proper informed consent, etc. So it's a take-home point that the IRB is also trying to protect the institution and investigators, although first and foremost, the emphasis is always on human subjects. So I'm going to end here, and I'm glad that time is still looking okay. This is the second study I wanted to discuss because it highlights the FDA emergency exception from informed consent, or exception from informed consent in emergency situations or emergency research. How many of you have heard of Polyheme? What's Polyheme? Fake blood. Blood substitute, another way of putting it, right? Okay. So let's say the situation is your IRB receives an application. It's a phase 3 multi-center trial to test Polyheme for the treatment of traumatic injuries in which large amounts of blood are lost. So Polyheme was designed to be given in the pre-hospital setting. Okay? Now obviously, and actually our IRB reviewed Polyheme, so we did it here. Okay? So let's talk about the questions because, again, we're reviewing this. And let's start with beneficence first. So we're looking at the pros and the cons, or the benefits and the risks, right? Well, the pros, obviously, you're reducing the possibility of infection, no blood type matching needed. Shelf life at 12 months, boy, wouldn't that be nice? And of course, patients with religious objections to real blood could actually benefit potentially from a blood substitute. Cons, obviously, you may need more real blood when you get to the hospital. It could interfere with lab tests. It's still in the testing phase, but the big one, what's the big one here? I've already alluded to it. What's the big ethical issue with the Polyheme study of the three? Autonomy, respect for persons, informed consent, because in Polyheme, you can't get it. You're talking about, patients that have lost a massive amount of blood in a pre-hospital setting. Okay? There's no way they can give consent, and chances are their legally authorized representative isn't available to go through a consent form and give consent either. Okay? So the FDA does have an exception from informed consent for emergency research. Now this next slide is an example of what you should never do in PowerPoint. It's obviously very lengthy, but I put it there so that for those of you that may want to access this PowerPoint and read through it, the take-home message is that you can only invoke this exception in a very rare set of circumstances. And those circumstances have to be a life-threatening situation. Ideally, no alternative should be available. Because if there's an alternative that's available, it's very hard to ethically argue that the exception from informed consent. Okay? We have to be absolutely sure there's no way the subjects can get consent, and there's just no reasonable way to identify prospectively who might be in the study, trauma situations, okay? But we think, again, that the benefits outweigh the risks. So you're always thinking as well about beneficence. And related to addressing beneficence, you're going to ask questions on, is there any preclinical data available or any, brief or small clinical studies that have been done. We always look at that as well. Always look at that, even in this case. The problem is, and this is where we're going to end up, from an IRB perspective, the FDA says that you have to, this is called the community consultation requirement. Okay? And the community consultation requirement is trying to maximize the principle of autonomy, okay, from a community perspective. Okay, and so the FDA is vague, but it basically says an IRB has to be satisfied that procedures are in place so that a community is sufficiently informed about the study that's going to be taking place in their community and has the opportunity to give feedback and things of that nature. The question is, how do you do that? Okay, beyond that, there was no guidance. And there have been many things that have been tried, and they can be quite expensive. For the Polyheme study, the investigators did everything from appearing on radio talk shows, they ran advertisements on television, they distributed thousands of opt-out bracelets to local libraries in the community, and of course the situation there is, who wants to wear a bracelet 24/7 that says, if you're in a traumatic injury, and you're found down, that you don't want to be in the Polyheme study. It can be very onerous. This is an ongoing issue in emergency research, and it is not resolved. But it's going to have to be resolved because most of the research indicates that the major breakthroughs in trauma and emergency medicine research in the 21st century are going to come from time-dependent therapies ultimately given in the field. Okay, so that's an accept, and that's something, though, that IRBs grapple with. So let's do some take-home points. I appreciate you guys sticking with me during this lunch hour. IRB membership, big time, should be diverse and include community representation. Community representation would have prevented Tuskegee, definitely, as one example. Level of review is driven by level of risk, and that's going to determine your pathway when you are going to submit your protocol. Informed consent is a process, not a document. It is always a process, not just a document. We don't ever want, here, sign here. Okay, that's not informed consent. Okay. HIPAA requires written authorization for PHI collected and researched by a covered entity, which can rarely be waived, and the waiver must be granted by the IRB. But health information only becomes PHI and subject to HIPAA when it's paired with one of 18 identifiers. That's very important. FDA does allow for exception from informed consent in emergency situations, but IRBs really struggle, and investigators do as well, with the community consultation requirement, which I should go on record as saying is critically important because it maximizes autonomy for the community. We just need to figure out effective ways of doing it that don't waste resources, both for the investigator and for society. There's been town hall meetings that have been held and nobody shows up. And so we're still just trying to grapple nationally with what works. Failure of the IRB can lead to a suspension of all federally funded research at a university for a period of time. Minnesota, I believe, recently, and I think I'll end there, I came across an article a couple weeks ago where there's a psychiatrist at the University of Minnesota that enrolled a subject that was committed into a research study. Despite the fact that the mother was pleading with the investigator not to enroll this subject in the study, that the subject's mental condition was deteriorating, and the psychiatrist enrolled the subject anyway because there was a large amount of money per patient enrolled paid to the institution. And a couple weeks after that, the subject essentially almost decapitated himself, killed himself. And so that's probably going to trigger an investigation. And not to mention beyond sad. So these things are still occurring even today, and the IRB is there to hopefully minimize the extent to which it occurs. Okay, questions? I think I'm within my time. So the question is, what's the magic number for a quorum? It's based on the membership roster at any given time. So you can go online, because we have members coming in and coming out, and see what the membership roster is. For the gold board, the magic number is usually around 7, because we have like 13, 14. It's usually just a simple majority, 51% or whatever that would be, but it's totally dependent on what the total membership is as documented at that time. Very good question. Yeah. So the issue is sometimes it can feel like when you're filling out a protocol that there's duplication of questions. And I can tell you that to the extent that that occurs, the board is always open to looking at that duplicity and seeing can it be modified. And I think with the forthcoming KC system, which is being implemented, one of the things that will be nice, because it's not a proprietary system, is that we will ultimately have more control as a board to say, yeah, we agree, this is a duplicate, and we ought to eliminate the redundancy. So yes, we do look at that. It's a very good question. Best way to contact the board, you can always call the Research Compliance Office, which is 293-7073, or you can email or call me. yeah, well, I'm currently the chair for another couple more days of the Gold Board. I've been chair for 4 years, but I will remain a member of the board. I've been on the board for about 8 years. Questions from afar? I really appreciate your time. Thanks so much.